Some of them are presenting with the initial acute infection, swollen lymph nodes, pale gums, lethargic, off food, just that general kind of ill thrift. But we are actually getting a lot of dogs who are going from the acute through the subclinical and then sadly presenting in the chronic phase, which is only taking, realistically within kind of 6 weeks, we're seeing these dogs presenting in the chronic phase, which is really challenging.
I'm Hubert Hinstra.
I'm Gerardo Poli.
And this is The Vet Vault. It's happened. In late January 2022, an astute veterinarian in Mount Isa in Queensland diagnosed the first locally acquired case of the tick-borne disease, ehrlichiosis, in a Queensland dog. As predicted, the disease is making its way down south. And we want to make sure that you, like our Mount Isa vet, are able to spot and treat ehrlichiosis when it comes knocking on your door. And if you're from the southern states of Australia and you're thinking, thank goodness I don't have to deal with this horrible disease, so I don't need to listen to this, think again. As you'll hear in this episode, while it's highly unlikely that ehrlichiosis will become endemic south of around Brisbane on the east coast and Geraldton in the west, it is very likely that cases will pop up anywhere and everywhere due to travel from time to time. So it's worth being aware of at least what to look out for and what to recommend in terms of protecting dogs. In 2021, we released 2 episodes on the Vet Vault clinical podcasts about ehrlichiosis after the disease made its appearance in Western Australia early in 2020, with the bacteria very quickly deciding that it will also see you in the NT. In the first episode, we spoke to Dr. Paolo Pazzi, a medicine specialist from South Africa where ehrlichiosis is an endemic disease and is commonly seen in practice. This episode is all about the clinical aspects of the disease, the pathogenesis, clinical signs, testing and treatment. Basically, getting you ready as a clinician to make sure that you don't miss these cases when they first start appearing in your hospital, and to give you a guide on how to manage them from someone who's been treating these cases at a high level all of his career. After we released this episode though, we had some feedback from vets working in the midst of the Australian outbreak, and it wasn't good. The message was clear. It's here. It's serious, and is not quite the same disease in Australia as it is in countries where it's been present for a long time. So we made a follow-up episode in late 2021 with Dr. Katy Davis, who works in Karratha in Western Australia where the outbreak sort of started, and with Professor Peter Irwin, the guru in all things vector-borne diseases in Australia and possibly the world. In part 2, we discuss what the situation looks like here in Australia, what we can expect, what to do and how to test when you see your first case. And we clarify some of the confusion around disease prevention. We've rolled both these episodes into an edited sort of a how-to guide for Australian vets. Listen out right at the end for a state-by-state resource guide on who to contact if you have a case and where to send samples. We've also put links to these in the episode description and in the show notes, of course. I've also done a little addendum on prevention products, as I had some questions of my own for my pets about what the best products are to use. Also, a quick thank you to a sponsor. We're mentioning a lot of products in this discussion, so I contacted the guys at Ehrlichia Australia to see if they'd like to support the podcast financially, seeing as Seresto collars, which is now one of their products, keeps getting mentioned, and they kindly said yes. So, officially, thank you Ehrlichia Australia for supporting the Vet Vault. I will take a moment to plug a flea and tick product of theirs that I didn't know existed until recently. Credelio, which contains lotilana, which you can hear by the lana is one of the isoxazolines, like alfaxolana, florolana, sarolana, all the ones that are really good for tick paralysis prevention. Credelio is a monthly chewable tablet with fantastic efficacy against ticks, including paralysis and brown dog ticks. But as you'll hear from this discussion, along with all of the other drugs in this group, it will not be sufficient to protect against ehrlichiosis. Let's jump in and find out more with Dr. Paolo Pazzi.
Paolo, can I quickly just ask you, the first thing that confuses me, everybody here calls it a bacteria. I thought it was something else. Is Ehrlichia bacteria, or what kind of parasite is it?
It is actually a bacteria, and it's a special kind of bacteria because it's not your typical bacteria that just gets into the bloodstream and gets taken away by neutrophils and that sort of thing. It goes and lives inside the monocyte, so one of the white blood cells, and goes and lives inside there. And essentially by doing that and living inside the monocytes, protects itself from the rest of the immune system. So it's a clever little bacteria that has learned to escape and evade the immune system. And that's part of the reason why you get different phases of Ehrlichia.
Paolo, in South Africa, what's the tick that spreads the bacteria, Ehrlichia?
It's the brown dog tick, so the Rufficephalus sanguineus. Is that the same one you have there?
Same one, yeah. Same one here.
Okay.
So in terms of where it is probably going to go, that tick, so if you Google the cattle tick line in Australia, that's sort of a line that cuts the northern coastal region of Australia all the way down, pretty much all the way down to Brisbane, all along the coast. And as far as we know, the dog tick, Rufficephalus sanguineus, follows roughly that line, maybe a little bit further south. So it's unlikely that it will become completely endemic in the southern half of the country. Up there, it looks like it will probably become endemic. They haven't declared it as such, but they're seeing lots of cases. So it's there, it's coming. It's there and it's coming.
There's no chance of kind of tackling this and getting rid of it now.
It's not an indefinite no, and nobody's saying it is endemic, but the numbers they're seeing, it is a hard one to get rid of. I don't know, Paolo, if you can talk to that. Why is it hard to get rid of?
I mean, once it's there, it is extremely hard to get rid of because it can live or harbor in the tick for over winter, basically. So you think you got rid of it. But also, if it bites a dog that's in the chronic phases, it can pick up the parasites or at least the bacteria again and then start spreading it all over again. And the problem is you do have carrier statuses in dogs. So they go into a subclinical phase where they're not showing any clinical signs at all, but they could possibly still transmit it to a dog. So you think you got rid of it, and then a year or two later, it pops up again.
Yeah. What's the impact of this disease in South Africa?
That's very difficult to assess. I mean, you'd have to take it on a case-by-case basis. We do see a fair amount of Ehrlichia, probably. Sure, I don't think a prevalence study has been done, but you're looking at about 2 to 5% of dogs in our hospital anyway that do present with it. And the effects on the dog, some of them are subclinical and they can completely clear the infection on their own, but a number of dogs will be very clinical for it, very sick, and they do require treatment. So it does have an impact on both dog and owner.
So I have very vague memories of it. So I left South Africa long ago and only practiced there for probably 2-3 years. All I remember about Ehrlichia is anything that comes in sick or with a fever gets a blood smear, and we were looking for babesiosis. Babesio is easy to diagnose on a blood smear, whereas Ehrlichia not. You could sometimes see it sitting in the monocytes, but if you saw neither and the dog had an unexplained fever, this was obviously not a high-level practice, but we basically just put them on doxy because in case it had Ehrlichia. So enlighten us. I'm sure that's not the way it should be dealt with. Well, first of all, what do they present as, Paolo? Refresh my memory and tell everybody. If you've never seen it before, I've got a dog come through the door. What should I be looking out for that's going to make me think, oh shit, I should be testing for it?
Sure. So sometimes it's extremely vague. The dog just presents with lethargy, anorexia, and just not itself. But most of the time, I'd probably say 90% of the cases, you've got something that's giving you a hint that there's a possible Ehrlichia going on. The most common hints are going to be that the lymph nodes are enlarged. So you've got peripheral lymph adenopathy. And it's not lymphoma size, but I mean, you're looking at about 1.5 times to 2 times normal. So you need to feel those lymph nodes, and they can be subtle, but they often are quite enlarged. And when you do an abdominal palpation, a lot of time there's a splenomegaly as well. Because the parasite goes and lives in the white cells, it still causes an immune reaction, and that's why you get enlarging of those lymph nodes. I don't know if you guys do blood smears routinely, because as you say, everything that comes in South Africa gets a blood smear, and because of the babesia. But if you do a complete blood count, if you're not doing blood smears, thrombocytopenia in the acute stages is typical. So you're going to see it's not going to be the typically it's not the thrombocytopenia of immune-mediated thrombocytopenia, so it's not sitting below 30. It's usually sitting in the range of between about 50 to 150. So that's a good clue as well that there's something going on. If a dog presents to me with petechia and ecchymoses and a bleeding nose, so if there's epistaxis, I need to rule out Ehrlichia, because surprisingly, epistaxis is quite a common presentation because of the thrombocytopenia and a few other things going on as well.
Yeah, because like the vast majority of the times, I mean, we would see a platelet count of 50 to 150 would actually be artifact from clumping and, the machine kind of reading it. So part of that, for me clinically, I would do a blood smear and check to see if there was clumping, right? And so then if you see no clumping and then you have a low platelet count, then that's when you get a bit more concerned.
Yes, exactly. Definitely. And then, as you say, you can look in the monocytes. In the acute stages, it's quite nice to pick it up. You have to be careful. Okay, we have babesia, but if there's something else going on with your dog and your monocytes are phagocytizing red blood cells for any reason, it can be difficult to differentiate. And the actual bacteria itself, they're quite small, but they're often in a circular shape, and there's little, almost looks like granules within that circular shape within the monocyte itself. But it's very poorly sensitive. Even in the acute stages of the disease, you're probably looking at about 10% to 15% of dogs that are going to have that on a peripheral blood smear. It definitely doesn't rule it out.
So where are we for testing at the moment? How do we confirm it?
So you need to have, obviously, the clinical suspicion. So your thrombocytopenia, your enlarged lymph nodes. Sometimes there's a mild anemia as well. I don't know if you guys have serology at this point. So usually our first step is going to be immunofluorescence antibodies, so serology, IgG and IgM, to see if it's positive. So of course the IgM tells you that it's an acute infection. Yep. And that's going to go up after about, depends on the dog, but about 5 to 7 days after it gets infected. So you can send away for an IgM, and if that comes back positive, you have acute Ehrlichia. Okay. You can send away for an IgG as well. So that's the one that stays up for months to years after you have an immune reaction. The problem with that one being positive is that some dogs that are exposed to Ehrlichia, they are going to rid themselves of the actual bacteria. So they don't necessarily continue to have the disease. So you have to be careful of a positive IgG. It may just mean that they've been exposed to the Ehrlichia before.
Okay.
Yep.
So that for me is generally the starting point, and it depends on my index of suspicion and whether those come back as positive or negative. Because if it is the very early stage, you may not have antibody production just yet, and then it is a good idea to run a PCR as well.
Okay.
To look for the actual DNA of the bacteria. So the problem with that, of course, is you need to have circulating parts of Ehrlichia or Ehrlichia DNA in your sample for it to be positive. Right? It's not going to be positive if there's no DNA in your sample. So you're collecting a random blood sample from this dog, probably 2 mils, 3 mils, and you're sending that off and hoping it's positive. So you can get false negatives with the PCR.
Oh, wow.
And
I thought it would be like super sensitive, like so sensitive, like most antigen tests, it picks up this tiny little amount. You're not too sure if it's clinically relevant.
No. So you can get false negatives, and that's the problem with the test. The PCR, if it comes back as positive, that's perfect, because then nothing else is going to do that. But if it's negative, it also doesn't rule out completely. But usually these dogs that you are suspicious, they are going to have, the easiest and cheapest for us anyway is to do an immunoglobulin. It's just, if it comes back positive and your dog's clinical signs fit, you're going to treat for it.
Okay.
Yep. And that's your IgM we're looking at, yeah?
If it's the acute phase. Now, though, you got to be careful, because it's sometimes very difficult to differentiate acute from chronic, okay? Even the chronic ones can sometimes have enlarged lymph nodes and an enlarged spleen. And if I'm going to test for Ehrlichia, I'm going to do both. I'm going to do IgM and IgG, and then relate it back to my clinical findings and my hematology results.
And why is it important to differentiate acute from chronic? Like, do you treat them differently? What does it mean for us in practice?
So that's a good question. You don't necessarily treat them differently, but the chronic ones tend to have more problems. And what I mean by that is they can live in the subclinical phase for months to years, and they have absolutely no signs. But what they're doing, and you don't realize it until all the bone marrow is destroyed, is that they're destroying the bone marrow. And then if it is chronic and you have pancytopenias, and we're talking red cell, white cell, and platelets, if you have that, your prognosis becomes poorer for recovery, depending on how low your white cell count is or how low your red cell count is.
Okay. So that's even if you eliminate it with like the treatment, doxy, something like it, the damage there is chronic and it's irreversible or something.
Exactly. So now the prognostic indicators are a persistent anemia of less than 14, and a persistent neutropenia, so leukocyte, and specifically neutrophils of less than 1, if you have that on your initial blood work and you diagnose Ehrlichia, the chances of recovery are quite small. That bone marrow is unlikely to bounce back. And you need to treat them the usual course of doxycycline, and then you need to give supportive treatment, because as you can imagine, if the white cell count is less than 1, your dog's very prone to opportunistic infections and that sort of thing.
Wow. So what do they call that? Like myopathitis or something? I can't even remember the words. It's a scarring of the bone marrow or something.
Yeah, myelophthisis or myelofibrosis, depending which one you have there.
So how does it work? Because if they sit in the monocytes, how does it start destroying the entire bone marrow? What's the pathogenesis in that?
We don't actually know. There's been very little research into exactly how it destroys the bone marrow. So with the acute phase, there's thought to be an immune component and that's why you get the thrombocytopenia, because it's actually partly destroying the platelets through an immune process. But in terms of how exactly it destroys the precursors or affects the precursors, it's not clear. We don't have a clear answer on that.
So treatment-wise, are we at treatment? Or are we missing anything? Are there sneaky ones that we're going to miss? Clinical presentations, things like that we're brushing over.
The other thing that might point you in the direction of Ehrlichia is hyperglobulinemia.
Okay.
And you've got to be careful of those, because the differentials are, of course, things like lymphoma and multiple myeloma. And they can be surprisingly high, these hyperglobulinemia, sometimes sitting in 65, 70 zone. So that's quite high for globulin. So that's just something else you might pick up on your biochemistry that will point you in the direction of Ehrlichia.
So are we at treatment?
I think so.
Can we talk treatment? So
I just think in summary, this thing is a freaking pain in the ass.
It sounds like a pain
it is. Because you get such a mixture of presentations. I mean, and everywhere you read, it says it's difficult to differentiate acute from chronic, and it is important because it has an effect on your bone marrow. But you get such varied presentations, everything from just depression to the extreme of having absolutely no white cells left. And it can be such a confuser sometimes. Do I really have it? Do I not have it? And it's like Hubert said in the beginning, sometimes in private practice in South Africa, if you're just mildly suspicious, you're going to treat because we see it so often.
Yeah. So treatment, what do we do? So we've got our results back. Do we differentiate our treatment if we suspect it's chronic or acute, or is it just the same? Do we roll out the same treatment?
No, so it's the same. So it's doxycycline, 10 milligrams per kilogram, once a day for 28 days. Stock standard treatment. That's what acute or chronic gets. So there's variation. You can give the doxycycline at 5 milligrams per kilogram twice a day, because some dogs may not tolerate the doxycycline so well, but it's still 28 days. There's been a lot of articles on how long you should be treating for. And one of the concerns is that even after a doxycycline treatment of 28 days, even if the owner is very good about it and gives everything, that the parasite, or at least the bacteria, can persist. And what's amazing about this bacteria is that usually you see a clinical response. So the dog does clinically much better after about 2 to 4 days, dramatically better.
Okay.
But the hematology lags. So if you had a thrombocytopenia and that sort of thing, you're probably going to see, you do see an improvement about 7 to 14 days later. Okay. But that is a stock standard treatment. The concern, like I mentioned, is that sometimes it comes back. And this is even if the dog hasn't been exposed to ticks or the owner is very good with tick control. They do get relapses sometimes. The exact prevalence of relapse isn't clear, but you should be retesting your hematology in about 4 to 8 weeks after your doxycycline course is finished.
Okay.
To see if there's any signs of your thrombocytopenia, or you can also, by the way, I forgot to mention, you can also get a monocytosis with this whole disease as part of your CBC results. Okay. So if any of that comes back, then you need to be worried that you may have recurrence of the Ehrlichia.
And are we monitoring our hematology during the 28 days? Like how frequently would you be getting it back in and checking bloods on it?
Yeah, so there is some recommendations. It has to be what you're comfortable with. I don't stick quite with the recommendations, to be honest. I think it's a little bit of a waste. What I tend to do is about 7 days after I've started treatments, I get them back and make sure, 7 to 10 days, make sure that the CBC and the platelets are at least looking a bit better, and it's on the road to recovery, and the dog's doing better, and the lymph nodes are smaller, and all that sort of thing. And then the next time point that you should be doing a CBC is at the end of treatment. And really you should have normalization of your cell lines by then, you know. And then after that, you should see them again in 4 to 8 weeks, repeat the CBC and see what's going on then.
And are we rechecking any of the serology or the PCR at any stage, or to check
So
whether it's cleared
serology
or not?
That's a great question, because serology is not good to use, because unfortunately it will be positive because the dog has been exposed to it. So it can be positive for months to years, especially the IgG afterwards. So that shouldn't be used for monitoring. But you can use the PCR for monitoring. So we have seen a number of relapses, and then we send off the PCR. And sometimes it comes back as positive and sometimes it comes back as negative. And that's pretty much for the reason I mentioned earlier. You may just not have the actual Ehrlichia in your sample, and you're just unlucky. But if all the clinical signs were exactly the same as the first time, even if your PCR is negative, then I'm going to treat anyway. If the dog resolved in doxy and the signs came back, even if PCR is negative, I'm going to treat. So in an ideal world, you're going to check your PCR again at 4 to 8 weeks to make sure that it's gone, that there's no more circulating Ehrlichia. But that's often expensive. It is expensive to run a PCR, and it's often not practical. So we base a lot of our decisions basically on a CBC. Because there's a lot of controversy as to whether you should be treating an asymptomatic dog that has a positive PCR for Ehrlichia or not. Because if a dog comes back positive for PCR and its CBC is completely normal and the dog's completely normal, will it not rid itself of that infection?
Is the relapse due to reinfection, or is the relapse because we haven't quite eliminated it and it's coming back?
Most of the time it's because you haven't eliminated it properly and it's coming back.
And do they must get some degree of immunity? Like, will you get, if it's had it once, can it get reinfected? Because you have these lingering antibodies. Does it lend any protection or not really?
No, the antibodies don't, because it goes into the monocyte. So if the bacteria gets the monocyte, then the antibodies pretty much don't work. So there's no ongoing immunity, and they can get, if your owner's not bad and doesn't treat for ticks, then reinfection is definitely possible, because they obviously got it the first time.
Because we talked about relapses and so forth. Is there a way of being sure that a dog is clear if it's moving out of a tick zone? Is there any way of telling who may have future relapses?
Sure. So there's the best you can do is to treat a dog for 28 days. That's your best option. Wait 4 weeks, and then in a perfect ideal world, to try to make 100% sure, is you should get blood, you should get splenic aspirates, and you should get bone marrow aspirates and send those for PCR.
Well,
because it lives in the spleen and it lives in the bone marrow. So the only way to make sure a dog is and even then you may miss it, but the chances are small that you'll miss it if you take samples from all 3 of those sources. So blood, spleen, and bone marrow. So it's quite a invasive process to be 100% sure. And a splenic aspirate, you don't need to take a chunk of spleen, but still it requires some
multiple aspirates, Paolo, or just you just pick one? Because I know
I don't think anyone's comfortable stabbing the spleen.
No, it's a good.
We stab spleens every day. I mean, you need to get enough sample for them to run a PCR. So it's really not a lot. I think it's 100 microliters for them to run a PCR. So you just need enough of that sample.
Oh, okay. So it's not cytology to look at. They look at PCR. So you're sticking it on the spleen by ultrasound, and you suck some blood and get some blood out, and you're like, done. Get the needle out.
Exactly. Yeah.
Is a snap test available? Because apparently there's one available in the US.
So the one that I think Andrew is talking about is a VET4DX test, which also tests for the more endemic things in the US. We do have an Ehrlichia snap test here, which is just a basic, it's not an IDEX test, but it's a simple kind of almost like parvo looking test. That's not a snap test. And I don't know the sensitivity and specificity. You have to pick up antigen, and I think a fair amount. So if it's positive, again, it's useful. If it's negative, I'm not convinced it rules it out.
Okay.
Because we don't use them routinely here.
Okay.
The VET4DX test in the States is very sensitive and specific, but it's a little bit of a waste because it tests for the other 3 diseases as well. So it's like 97% sensitive and 98% specific. So it's a very good test to run. But on these little once-off Ehrlichia tests, we don't know the sensitivity, to be honest. So just so that you know that one can be very good and we don't know the other one.
So other treatments. As soon as you said an immune component to wiping out the bone marrow, are we giving them immunosuppressives, or is there anything else we give, or is it just there, have your doxy, good luck?
So have your doxy, have a nice day. So prednisolone has not been shown to improve outcome at all. It doesn't improve the rate the bone marrow responds. It doesn't improve how quickly they clinically respond. So the only time we do is when we think we have Ehrlichia and it's the cause of an IMTP. So in other words, an immune-mediated thrombocytopenia. So if your white cell count is sitting less than 30, it just becomes less likely that that's caused by Ehrlichia. And if it sits down at 10 or 7, if your platelet count keeps sitting that low, then you probably have an immune-mediated thrombocytopenia secondary to your Ehrlichia. And we do think that we see a lot of autoimmune diseases secondary to Ehrlichia. So that's something else to keep in mind. As a sequela of Ehrlichia itself, you can get an autoimmune component, including IMHA and including IMTP. So I would never use prednisolone in a dog that has a platelet count of 70, because then it's not IMTP, but only if it's sitting really low, and I think it's a cause of the IMTP.
I'm surprised that they actually had clinical signs of primary hemostatic disease with platelet counts of, I don't know, 50-ish or something like that. I don't know, clinically I just don't really ever see that. But I like the cutoff what you're saying, in a way that it's like, generally if it gets that low, then there probably is some kind of immune-mediated component. But if it's not that low, then maybe it's just the fact that it's just the infection itself. So
exactly,
Does it, I was thinking the same thing about the numbers that sound that low to start getting nosebleeds. Does it affect the functionality of the remaining platelets? Like, are they
that's
less?
The thought. Yeah, that's the thought, is that it's either the parasite itself, which seems less likely, but the more likely contributor is the globulins that bind to platelet surfaces and then affect their function. So that's one of the bigger contributors to dogs actually showing petechiae and ecchymoses and all that sort of thing.
Damn, who brought this freaking thing into the country? That's a pain.
I was just thinking.
There was one other question about vitamin B12.
Yes.
Vitamins come up quite a lot, but is there any proven benefit with using vitamin B12 as part of your management regime for this disease?
No, not to my knowledge. No.
So literally nothing else. No clove oil or turmeric or anything.
No. So the only times you've got to think of adjunctive treatments is when they are in this chronic pancytopenia phase, and then it's supportive care. And there's a little bit of controversy about if the neutrophil count is less than 1,000. So less than 1, do you start antibiotics? Do you not? So my thought process is, if the dog is eating and normal and not febrile, then if you're starting antibiotics in that stage, all you're doing is breeding for resistance in your dog, because the only bacteria that are going to survive are the ones that are resistant. So in my opinion, and again, there's controversy, you should wait until the dog's febrile, so that whatever first-line antibiotic you do use is likely to be more effective, because the majority of infections they do pick up are opportunistic. They're not necessarily severe pathogens.
That's a really good thing you covered there, because we get neutropenic or leukopenic patients part of chemotherapy, and then everyone's kind of like threshold for how brave they are and holding off antibiotics is different. So sometimes we start when it's less than 1, because it just sounds really bad. But I like what you said there. That kind of really resonates with me.
It's very controversial though, and some oncologists will start at less than 1 or 1.5, but for me it just doesn't make sense. You're breeding for resistance basically.
Okay, that was the clinical part. Stick around for Dr. Katy Davis and Professor Peter Irwin's discussion on what things look like for us and our immunologically naive patients down under. A quick reminder about our clinical series of podcasts. If you enjoy staying up to date by listening and learning while you're on the go, like this, then you'll love our clinical podcasts. 3 short episodes per week in small is medicine, surgery, and emergency and critical care with world-class specialists. I was doing a list of all our guests to date the other day, and it's pretty bloody impressive. Sharing all of their hard-earned insights and updates to make sure that you are a total boss vet, without having to sacrifice hours and hours staring at a screen or a textbook. All backed up by beautiful show notes that summarizes all the bits that you'll need to refer back to. Check it out at vvn.supercast.com. Seriously, you're missing out. All right, Prof. Peter Irwin and Dr. Katy Davis. The situation in Australia, you're right in the thick of it up in the north there, yeah?
Yeah, absolutely. We're seeing it every day. Every day it's coming in. So unfortunately, initially when it started, we were seeing a lot of the dogs coming from the communities outside of Karratha. They were coming in and testing positive, but now we're getting positives well and truly in the middle of the towns.
So these are well cared for pets that are coming down into Ehrlichia.
These are well cared for dogs who sleep in pajamas, on couches, you name it. It's effective tick prevention as what a lot of people were doing here. So a monthly oral preventative, and unfortunately, yeah, we're still getting positive tests.
Okay, so we'll come back to that. I want to ask Peter to give us a rundown of the actual transmission and all of that so we can understand how to have effective prevention. What are you seeing, Katy? What are they coming in as? Are you just seeing fever dogs coming in? Are they coming in bleeding? What's the sort of clinical picture that you mostly see?
I put it in two groups. We're definitely still, because we work a lot with a rescue organisation, SAFE, we get a lot of dogs, again, out through communities, etc. They're coming in and we test every dog that goes through that organisation. So we are seeing a lot of positives that would probably otherwise not be picked up.
Okay.
But then our second group is the dogs who you wouldn't suspect, the dogs from, in town, well cared for, that side of things. Some of them are presenting with the initial acute infection, swollen lymph nodes, pale gums, lethargic, off food, just that general kind of ill thrift. But we are actually getting a lot of dogs who are going from the acute through the subclinical and then sadly presenting in the chronic phase, which is only taking, realistically, within kind of 6 weeks, we're seeing these dogs presenting in the chronic phase, which is really challenging.
Remind us again, Peter, the chronic phase, what do they look like?
So the chronic phase dogs are usually emaciated and they're very thin, they're not eating. It's been a sort of progressive decline, I guess. They'll often be febrile and they'll also tend to bleed because the classical understanding of this disease is that the chronic phase is the sort of bone marrow failure phase. So those dogs are very liable to sepsis, hence the fever. They become anemic, they are thrombocytopenic, bone marrow has failed, and so they bleed as well. So, you can get that sort of combination of signs. And it's interesting what Katy says about this really rapid progression from what might be, acute disease to chronic disease. And that's something that practitioners are reporting all around Australia during this outbreak, and that's different to the, if you like, conventional wisdom, or if you look at, if you read a textbook, people talk about that chronic phase being months to years later even. But I think that we have a unique situation here in some respects. The canine population is naive, so none of these dogs have ever seen Ehrlichia, of course. Plus, we have very heavy tick burdens, particularly in the communities that Katy was referring to. So it's a combination of high dose of Ehrlichia, a naive population, and we're seeing this rapid transition of disease in chronology.
Now, one of the biggest feedbacks I got from that episode when we asked Dr. Paulo, what do they do for prevention? What's an effective way to prevent it? He was pretty casual about it. He said pretty much anything that's going to kill a tick is going to prevent it. And I had quite a few people, including Katy, saying, not the case for us. You have to be more astute than that. Before we get into actual products and protocols, talk to us about the transmission, Peter. How long does it take from bite to infected? What's the pathophys behind it?
Okay, so any stage of the tick can pick it up. So larva, nymph, or adult. And you remember that ticks only feed once. So they will then have to molt into the next stage before they can transmit it.
Okay.
And interesting, actually, the females can't do that. So the next stage after a female are eggs and larvae, and this is not a transovarially transmitted disease. So larvae can't transmit it, unlike Babesia, for example. But larvae will transmit babesiosis because they're transovarially transmitted. That's not the case for Ehrlichia. So nymphs and adults will transmit to the dog. Okay. And so the thing about this that is so critical from a treatment or preventative perspective is that there's now plenty of research to show that Ehrlichia canis is transmitted within 3 hours.
Wow.
Within 3 hours of biting. So,
Okay.
almost instant. It's not quite as instant as a mosquito transmission or a sandfly transmission, but it's within 3 hours of the tick beginning to attach. And that's absolutely critical in understanding how to prevent Ehrlichia in any given dog, because although the group of drugs that we use most commonly these days are isoxazolines, they're an excellent group of drugs, but they rely on the tick having attached and been biting and been feeding for some time to work.
Yeah.
They've been very, very effective, for example, along the eastern seaboard in Australia, preventing tick paralysis. That's been amazing. But with this disease that's transmitted so quickly, you need a drug that kills the ticks or repels them before they even attach.
Okay, so what are we looking at? Katie, what are you suggesting to your clients there, and what do you find is working?
So we're typically suggesting a dual approach, so something like a monthly or a 3-monthly preventative, so NexGard, Bravecto, Simparica, whichever the owner is more comfortable with, but then also a second line or I guess it's a first line of defence, like Peter said, something to actually repel the ticks. So a Seresto collar where we can, or something topical like Advantix or tick sprays out in the communities as well to try and prevent the actual tick biting.
Okay. So let's go through the repellents. What are they? And feel free to say brand names. I want to make this practical. What are the effective repellents?
Okay, so there are the two drugs that are available for preventing tick bite and tick attachment are permethrin and flumethrin. And these are available in, as Katie was saying, collars and a spot-on. So the Seresto collars contain flumethrin, which is an acaricide. It prevents the ticks from attaching and biting in the first place and kills them as well. And then also Advantix, which is the permethrin-based product, which does a similar thing. The important things about both of these drugs is that they have been shown through experimental study to prevent dogs getting Ehrlichia canis. So, it's all very well knowing that they kill and prevent ticks, but the studies have been done to show that they prevent this disease. So for individual dogs, this is the best way to protect them. The isoxazolines that Katie mentioned are very effective. Well, they're very effective at killing ticks, but once they've been attached. And they're very effective at reducing burdens in community too. We've had a lot of reports about when they're used a lot, that the tick burden overall, the sort of community or the environmental tick burden falls considerably. But unfortunately, those drugs will not prevent any given dog getting ehrlichiosis, and that's a message that has to be got across.
Okay, that's vital because we missed out on that one in the last episode. Katie, anything else there on that front?
Yeah, no, I think exactly what Peter said. I guess here the practicality and like we're saying, if we could get a Seresto collar on every dog, then we would. But when it comes down to the actual practicality of it, that's where we're really, really struggling.
Okay. And now, in terms of distribution in Australia specifically, so it's the brown dog tick. Yep, brown dog tick. Yeah.
Brown dog tick. Yeah.
Theoretically, how far can it go based on climate and distribution of the tick? How far south should we be expecting it?
Okay, well, the brown dog tick's sort of enzootic range. That means it's the range where it's naturally found, if you like, or comfortable being found, is all throughout the tropics, so north of the Tropic of Capricorn. But because of Australia's geography and climate, the tick has been found well established, well into southern parts of the Northern Territory and northern parts of South Australia. So there's a sort of dip there in the middle of Australia. Yep. And then it extends down each seaboard quite a long way, so down to Geraldton and even down to Kalbarri on the west coast, and down the east coast, probably even as far as Brisbane and on into northern New South Wales. Okay. And that's where the climate is suitable for the tick to even thrive. But what's important about this tick is it's referred to as being as an endophilic tick, which means it's adapted to domestic or household living. It's evolved with domestic dogs for a very long time. Okay. And so it actually has a unique ability to be able to survive in houses, in places far from its endemic range. And this has been particularly well described in Europe, where the tick has come up from the Mediterranean and has established in northern Europe. We think of Germany, the Netherlands, even in Scandinavia and the UK, where it can...
Not very tropical up there.
Not very tropical, you're absolutely right, but centrally heated houses, and the tick can survive. And if it's a female, gravid female, for example, she'll lay her eggs, they won't desiccate. If it's warm enough and not too dry, they won't desiccate, they'll hatch, and those ticks will survive. So you get these clusters of ticks surviving quite well in those locations. Now, Melbourne, Sydney, it'll be a very long time before such places have lots of brown dog ticks. It's going to have some pretty serious climate change for that to happen. But I think it's worth reiterating that this tick can survive well beyond its range. And of course, travelling pets and travelling ticks are the problem.
Yeah, so we all have to kind of keep it on the back of your head. If you live in Melbourne, you're not going to be seeing regular cases, but you might see the odd travelling dog bring it in. But all the way up to Brisbane, you say Brisbane, we could expect that it might become a more regular. So, and then diagnosing it, we talked about a PCR when we talked to Dr. Paolo. What's the current standard, Katie? What are you guys using? And Peter over here, if you think you've got one, where are we sending it to? Is it still funded by the government? Just basically, what's the current situation with testing for it?
Yeah, so at the moment we were waiting to see after the state election over here whether it changed from exotic to endemic, but currently it's still considered exotic, a notifiable disease. So every dog suspected, every dog tested goes through the DPI labs. Okay. So essentially a dog that comes in, if we've got high suspicion, we are running a 4DX in clinic to test for heartworm or anaplasma. Mm-hmm. And, coincidentally, if it comes up for Ehrlichia as well, we're obviously aware of it there and then. The thing with the 4DX, and Peter will be able to correct me on this, but I believe the 4DX is missing some of the particular Australian strains where you can get a negative in the 4DX and then you send it away for PCR and it does come back positive. But we do have the ability to obviously then pick up our Babesia and anaplasma as well, which we are seeing a combination of. So basically every dog will get a blood smear where we have a look, obviously, for the marule. We do a CBC prior to any dog undergoing surgery in our clinic because of the high chance of thrombocytopenia. And we are picking up a lot of dogs who are coming in just for their routine spays, routine dentals, etc. Every dog now gets a CBC prior so that we can have a look. Obviously, if we see a monocytosis and a thrombocytopenia, we're then having a chat to the owners, doing a 4DX or sending the blood straight to DPI to have a PCR and ELISA test.
Wow. Yeah, that sounds like my days in South Africa. You didn't touch anything with a blade, but at least looking at a blood smear.
Yeah.
Yep. Anything to add with the diagnostics there, Peter?
No, just to reiterate what Katie said, that there seems to be a sensitivity issue with the SNAP 4DX kit by IDEX. And so PCR is the gold standard, I guess, at least for acute infections. One of the problems we're going to have as veterinary practitioners in Australia with this disease is that once they get into a more chronic phase, and I'd be interested to hear what Katie is finding with cases that might have been more chronic, but it is known that the PCR becomes less sensitive because the DNA of the bacterium is not in the blood all the time in more chronic cases. Okay. And people have done studies to show which tissue type is more sensitive or better to use for a diagnosis of Ehrlichia. And that's included lymph nodes, and I guess a lymph node aspirate is easy enough, but spleen or bone marrow, are not really feasible. So that's something to bear in mind, that the sensitivity of the PCR decreases with time, but then this feeds into the success of treatment. To actually determine if a patient is cured is extraordinarily difficult. In fact, I'd even say it's really impossible unless you're doing serology and titers, like immunofluorescent antibody titers, and you actually get a titer and you follow that dog over weeks, months or years, and you can show the titer comes to zero. And again, this is impractical. Yep. It's very difficult to know if you've successfully treated a patient or not.
Just to have a quick question for Peter on that one. In terms of acute infections, what is the current timeline in terms of somebody sees a tick on their dog? How early would a PCR test be able to pick up? Is it basically in that first week after the bacterium has been transferred?
Yeah. Well, I think it's less than that, and there are studies that have tested exactly this. I think it's 2 to 4 days. The speed. Yeah, we talked earlier about the bacterium being transmitted within 3 hours, but of course it then takes a while for the bacterium to multiply and get into the bloodstream. My recollection is it's 2 to 4 days. It's certainly much less than a week.
Yeah, so we stick from a practical side, if somebody rings up and they say, I've seen a tick on my dog, I want to get it tested, we go at 1 week post that incident just for kind of a practical buffer. Would you change that and decrease it down, or do you think that's okay?
I think that's all right.
And then you're doing a PCR for that in that instance, Katie?
Yep, a PCR. So because again, it's still a notifiable disease,
Yep,
every animal with suspicion and that is included in terms of location, it gets a PCR test. I guess going back to what Peter was talking about, I think I would have liked to chat to Peter about it as well, because we are seeing such a speed between the acute, subclinical and then chronic phases. So far, I haven't, any dog that's kind of in that chronic phase that I've sent away a blood test for PCR and ELISA, the blood tests have supported our suspicion. So I haven't come across one as of yet where I'm convinced that the dog is infected with Ehrlichia and I'm not seeing it on a blood result. So I don't know if it's whether we're seeing that speed across the acute, subclinical, chronic so fast, or, in a year or so, once we've had a few more, whether we're going to start running into that problem of where we actually should be aspirating and testing.
Yeah, that's right. It's really interesting. Again, we're using the sort of conventional wisdom, aren't we? We're using the literature here that talks about this problem, but then the literature that's been published overseas has a different epidemiological or different chronology of the disease, at least, to what we have here and what we were talking about earlier. So I think you're right. At the moment, PCR in the blood in all these cases might be fine. But as we get further down the track, and I'm sure in South Africa with endemic stability of this disease, that's an issue for them as well.
Yeah. So practically speaking, what are the guidelines at the moment, Katie, for dogs moving out of that area? Let's say a rescue dog, which is quite a common thing. Like, do you have guidelines? How do you decide, okay, you're okay to move to Melbourne from Karratha?
Yeah, so look, this has caused a massive headache for me all this year. Currently, WA only has a dog movement guideline and a strict hard border, technically, out of the Kimberleys. So from the Kimberleys down, then dogs have to have proof that they are negative and they have to have proof of tick prevention to move south. However, in saying that, like I said, going back, we work very closely with SAFE, which is a rescue organisation, and I've worked very close with them to basically come up with a guideline to ensure that we're not sending high-risk dogs down south, over east, etc., through the adoption process. So what we do now is every animal that comes, or every dog that comes through, they get the initial PCR test. If they're positive, they get the 4 weeks doxy, and then they have a follow-up PCR test 2 weeks after finishing the doxy as per the DPI guidelines, and then another 6 weeks after that second test as per the DPI guidelines. And then we actually are applying for a movement of dogs for any of these adopted animals so that the DPI can trace their movements if they head south. They have to show that they have appropriate tick prevention 2 weeks prior to moving south. And we also have implemented a waiver of sorts of, it's basically a nice little poster, and it's something we could probably share for other clinics working with rescue organisations. Nice little poster that basically says, hey, I'm a dog that's been adopted from an canis area. Please be aware that if I have been positive and I have tested negative, this may still be, it may still come back in the future. Just in layman's terms for owners, please look out for these signs and present to your vet clinic and make sure that your vet knows that I came from an canis positive area. So we're trying to put in as many safety buffers as possible for owners, for dogs, for vets working down south, because obviously they're not seeing it to the extent that we're seeing it. But it is a very, it's a pretty tedious process.
Well, comments, Peter?
Oh, that's very responsible. I think that's good.
But it sounds like you'll get the odd one slipped through the net. The test negative, potentially it could live happily somewhere and then flare up again.
Yep, that's true, in addition to all the others that don't get tested responsibly.
Yeah.
Because, that's the other thing. There's the whole movement of dogs across the north. There's an enormous movement of dogs between communities, but also in travelling people.
Katie, were there any things that when you started looking at this that particularly challenged you? Well, let's say anything that we haven't covered yet. You listened to the previous episode as well. Stuff that you had to phone Peter about and say, shit, I'm stuck with this, give me a hand, that you think it would be useful for listeners to know?
Yeah, I think it's starting to slow down now, but I think the scariest thing at the first was the fact that our dogs were dying, and for all reports, when you read the literature and people's experiences in South Africa, Southeast Asia, South America, their dogs weren't dying. It was just a case of every dog has it, give it some doxy and they're fine. But we were seeing deaths every day. I'm still seeing dogs. I had one just a couple of days ago die. And so we are still losing the dogs.
Is that despite treatment, Katie?
That's these dogs presenting in the chronic form, but it's only been weeks since they've been bitten, and we are getting a lot of dogs present in the chronic form, and unfortunately the bone marrow damage and they present basically spontaneous bleeding, and trying to turn them around is, yeah, we are still definitely losing dogs, own dogs and also community dogs. So I think that was the big thing, and I think at first a lot of people kind of brushed it aside saying, oh, it's fine, dogs survive with this. But that's not what we were seeing on the ground. And I think it's taken a little while for people to sit up and listen to what was happening here and now in Australia and seeing it as a little bit of a different response. Okay. Here we do see it in combination with anaplasma and babesia quite often. So we do get secondary complications from that side of things. I know I've sent Peter a couple of cases where the dogs are too far gone and the secondary immune-mediated diseases associated with it as well. The other really interesting thing that came about it that I have spoken to Peter about was the opportunity we had to follow pregnant bitches and see whether, when they were positive, see whether their pups were negative, which has been awesome just from kind of gaining our own data. And we've had both instances where a pregnant bitch has been positive to Ehrlichia, her puppies have tested negative, and vice versa, where we've had a negative bitch and the puppies have actually tested positive just from obviously being exposed to an infected tick. So we're seeing that side of things up here too.
Hang on, so the pup's not positive from mum. It's not transferred by mum's blood. It's they're just getting bitten.
No.
Yeah?
Yep, that's right. For whatever reason, the bacterium wasn't transmitted to the pups across the placenta, which is strange, isn't it? Because many other babesia can be, for example. So I guess keep a lookout, Katie, because you may yet find some.
Yeah, so we're testing, again, with the community dogs and the safe dogs, we get a lot of opportunities. So every bitch that comes through pregnant and then the puppies, and we're following it. And so far, no data's gone against what the current understanding is. I guess the only thing that we have to be very aware of up here is blood donors, obviously the potential to transmit it via blood donors. So all of our blood donors are now having to be screened for Ehrlichia as well.
Mm-hmm. And are you, again, screening with the PCR? Oh, yeah, you would. I was going to say, you're not just doing not just a 40X.
The 40X we only really use if you want an answer there and then in the clinic as much as possible. Every dog still gets blood sent to the DPI, so we never rely solely on a 40X.
Okay, cool. Is there anything else that we're missing, Katie, that you think people need to know about?
I think just the awareness, again, like Peter's mentioned, the ability for these ticks to live outside their known happy environment. With the onset, I know in WA with COVID, we're seeing travellers, everybody from down south is swarming up north. A lot of these people are very much of the mindset, my dog doesn't get ticks ever, and that's great from, a suburban backyard in Perth, but when they are moving north. So I think it's very important for vets to be aware of it and to really be pushing, especially in WA, Northern Territory, Queensland, obviously down to northern New South Wales, just that awareness that if people are travelling, that if they're not protecting for ticks, obviously the East Coast is a little bit safer because you guys protect for paralysis tick, but over here,
no, nobody uses it.
A lot of people are in denial, but trying to get that through to them now that, that it is the brown dog tick. If your dog's a dog, there is every chance that it's going to get a tick. And with a transfer of potentially as low as 3 hours, it's just not worth the risk.
Okay, a quick update on what to do if you have a suspected case of Ehrlichia. As of March 2022, the disease remains a nationally notifiable disease. This means that testing to confirm a diagnosis is still free. Regardless of where you are in the country, if you have a suspected case, you can contact the Emergency Animal Disease Watch hotline on 1-800-675-888. If you suspect the presence of E. canis infection in any dog in Queensland, you must report it to Biosecurity Queensland on 132523. And in WA, you can contact DPIRD Vet, DPIRD. Links are all in the episode description, including links to the appropriate labs to get it tested in each of the states. Now, a few more things around prevention. I spoke to one of the vets at Elanco and did a bit of Googling of my own to get some clarity on a few things around preventatives that I wasn't quite clear on. So here's what I've got for you. So we said that because of the rapid speed of transmission of Ehrlichia canis, we'll need to use a tick repellent to stop the ticks biting. We mentioned Seresto collars and Kiltix collars and Advantix Spot On as our tick repellents here in Australia. Only Seresto and Advantix have been shown to block transmission of Ehrlichia canis in dogs, but only Seresto has an approved label claim in Australia. So recommending anything else would be off-label, including Advantix and Kiltix. Advantix contains permethrin, so obviously take care with Kitty, and it should be applied monthly to repel and kill brown dog ticks. Seresto and Kiltix both contain flumethrin as an acaricide. Kiltix is the cheaper older generation collar and releases flumethrin within a powder that spreads over the surface of the dog's coat, while the newer technology in Seresto allows the flumethrin to penetrate into the lipid layer of the skin and coat and be continuously topped up as needed from the reservoir in the collar. This allows for a consistent dose of flumethrin on the dog that protects it from washing off if the pet swims, so definitely more ideal for your beach or river dogs. Seresto repels and kills ticks and reduces the risk of transmission of tick-borne diseases to dogs for 4 months. Now, my big question was, if I live in the tick paralysis area, which I do, and one day soon I might have to start worrying about ehrlichiosis, which I probably will, can I just use Seresto instead of my current tick prevention? So here's what I'm told. Yes, Seresto is highly effective at repelling and killing paralysis ticks on its own, but the guys at Elanco told me that considering the fact that a single tick surviving long enough to cause tick paralysis is so catastrophic that an ideal strategy to reduce the chance of tick paralysis even further would be to use the repellency of the Seresto collar as the first line of defense and a systemically acting azoxyzolline as a second line preventative or an insurance policy. We've all seen those cases where the pet is on the right tick control but then still comes in, especially towards the end of the protective period with clinical tick paralysis. The thinking is that having Seresto on board as a tick repellent that sustains its kill speed in addition to your systemic acaricide, that you will greatly minimize the risk of both ehrlichiosis and tick paralysis, and that should be our gold standard recommendation. I asked her my favorite question, but what do you do for your pets? And the answer was both. So there you have it. I hope we don't see ehrlichiosis in our clinic or your clinic for a very long time yet, but if you do, at least be ready.
Hi, I'm Hubert.
This is Gerardo.
And you are listening to the VetBomb Clinical Podcast.